2024 NEI Synapse features an educational program chock full of the latest advances in psychopharmacology and cutting-edge research on treatment strategies, side effects, drug interactions, and management. If you have yet to do so, register today for the 7th annual event being held April 19th through the 21st, in person in Las Vegas and online via simulcast. Use discount code PODCAST to save $100 on your registration at nei.global/synapse. Discount good on new registrations only.
Welcome to the NEI Podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI Podcast. Today we're talking about dementia caregiving and a new model called the GUIDE model, G-U-I-D-E. And with us, we have Dr. Carolyn Clevenger, a gerontologic nurse practitioner, and she's a professor at the Nell Hodgson Woodruff School of Nursing and the founder and director of the Integrated Memory Care Clinic at Emory University. Welcome, Carolyn. How are you?
I'm great. Thank you so much for having me.
You bet. Well, we have done episodes on Alzheimer's pathology and treatments for Alzheimer's, but this is another aspect that we haven't really talked enough about, and that's caregivers and what can be done from a caregiving point of view. So maybe we can start out overall with the prevalence of Alzheimer's and maybe other dementias and just start thinking about the whole ball of wax of dementias. And what percentage of these people rely on unpaid caregivers for support?
Sure. So I think our prevalence is around getting close to 7 million people in the United States alone, right? Living with dementia.
Yeah.
We still think about half of those are Alzheimer's disease, although I think that prevalence is probably a bit of a moving target with the emergence of the biomarkers now that we're being much more specific and objective in those determinations. Now, 85% of people living with dementia have a family care partner or caregiver who is providing them with support.
That's incredible. Well, of course, the prevalence of certainly Alzheimer's and probably all dementias is growing as the population ages. We know that. And sadly, we don't have any real disease-modifying agents. We can't sort of stop this. We just manage it, if you will. And I guess the issue, of course, would be for a paid caregiver, you have to have the ways and means to pay for that. So I can see why so many people rely on family or others.
Absolutely. I think the thing about dementia that I focus on both in supporting their family caregivers and then the paid caregiver workforce, so what we sort of understand about that, and then a care delivery model like ours at Emory is that, there are a number of chronic progressive conditions for which we don't have the cure. But that doesn't mean there's nothing we can do. There's actually quite a bit we can do to manage symptoms and maintain and optimize quality of life for a long time in this case, right? So the emergence from symptoms until end of life is around a decade. So 10 years of support we can provide to these patients and families.
I never thought about it like that. That's incredible. Why are caregivers, this is kind of a naive question, but for the audience, why are caregivers so crucial for the management of dementias such as Alzheimer's?
So in the case of dementia, again, there are other chronic and progressive illnesses, but because the symptoms are largely cognitive, that then affects your ability to self-manage. So dementia is not just another chronic condition, right? It's unique because you cannot self-manage in this disease, and your ability to self-manage declines over time and, of course, varies day to day. We all have good days and bad days. So that means you need someone, if you're not able to rely on your own well-being, your own drive to drive your care, then you would then rely on someone else to supply that. And that typically is someone who's near you, friend, family, or what we might call family, who would do all kinds of things. So there's actually a nice framework. I didn't create it, but that we like to use to describe caregivers. It's the DCAF framework. So that sort of identifies what it is that caregiver is doing. So are they providing direct hands-on care? Maybe they're providing emotional support. Maybe they're coordinating care. Maybe they're providing finances or managing that piece of it. So caregivers are needed to do all kinds of things, not just physical support, but so many other things to get this person through daily life. And as we train them in our Savvy Caregiver course, through days that are engaging and meaningful.
Yeah. Well, I can imagine even things like managing finances, managing care decisions. I've thought about this before. I think one of the things that we all fear the most is losing our faculties, losing our mind, if you will. And so it's an interesting distinction you're making between, I guess, medical chronic diseases, cancers, heart disease, and various other things, versus this one. I think most of us would choose the others. Nobody would want this, but you're right, it does place special burden on the caregiver. A lot more cognitive demand on the caregiver, I would say.
It absolutely does. It is a unique type of caregiving. Early in my career, I would get invited to talk about just family caregiving broadly. Like, I just know dementia caregiving. It is just, it's a unique component that it's different than other types of caregiving. And if you add on top of that, a very common symptom in dementia as it progresses, all types, is agitation, which includes verbal aggression, right? Physical aggression. And so many times that is targeted or directed toward the people around us who we're closest to, we're most comfortable with. We all know there are things we probably would say within our family we wouldn't say outside of the family. That's still true when you are living with dementia. And so you may be providing a lot of demanding physical caregiving while also navigating and trying to figure out how to respond in the moment to things that are maybe not related to reality, or a more challenging scenario are aggressive toward you or negative toward you, yelling, cursing from someone who's never spoken to you in that way. And you likely had a lifetime relationship with this person as their child or their spouse. So it really is just its own unique role.
That must be an incredible challenge, is when the personality changes like this you're talking about. And I've certainly seen this. We see disinhibition of all kinds, as you said, not only agitation, but psychotic symptoms, which can be terrifying, especially if the person is accusing you of things such as being unfaithful, taking your money, this kind of thing. It can be incredibly challenging. And so I would imagine education is critical here, to educate that this can be part of the disease process. This is not you. Would you agree?
Absolutely. Yes. So, we've done a number of what we call psychoeducational programs for family caregivers. So some of that is around understanding the disease itself. Then there are also these coaching sort of behaviors we try to instill with our family caregivers. So for example, some people do well with mantras. So there are things like, be mad at the disease, not the person. Or, when they're doing something and you want to react because it's the natural human thing to react. And maybe we'll say something like, don't just do something, stand there. These both come out of the Savvy Caregiver program. And then we also then train them not only on the person and their disease, but in our newest project, which is called Can Do, we're training caregivers as navigators, because you don't only have to know your person, you have to know the system that you are engaging in. And using system to describe healthcare is really a stretch for that word, but all the different elements, right? So you've got outpatient and community care. You've got what I call sort of healthcare adjacent, things that are private pay. And they're certainly providing supportive care, but we wouldn't consider them part of our healthcare system or the medical community. You still need to know how to navigate day programs, residential care, primary care, a specialist and a subspecialist, because, we love to specialize in all of these fields. And how do you navigate between all of those places? How do you identify when it's time for like higher levels of care? And then how do you figure out like who can sign? So now we get the financial system involved, and the legal system can get involved in a variety of ways. The last system we've been training these caregivers on is the family system, because you might be the primary caregiver, and maybe you're this person's child and you have siblings who have different opinions on the way things should be done.
That's right. I've certainly seen that. Yes.
Yes. So it's a lot to manage. And so some of it's sort of understanding, but then there's also the skills building components that we like to do. And we've drawn on so many different other fields. For example, we've been training caregivers with improv techniques, working with a local improv company here in Atlanta called Dad's Garage, because this person may say something to you that's unexpected. How do you then be a strong performer, communicator with them on the other side? You have more tools in your toolkit, as I like to tell people, as they're losing their cognitive capacity. You can rationalize and reason and be creative. And so
Yes.
maybe you need to use those skills to be with them in their moments, whether that is a calm moment, it's just not grounded in reality, or it's a more anxious moment that might represent something more challenging.
Yeah, it strikes me you're talking about parenting skills, and this is part of the challenge as well as the role reversal as a child now parenting your parent. I can imagine that's a difficult transition.
It can feel that way. I try to sort of discourage anything that would infantilize this person who is your parent, who did change your diaper. So certainly, you guiding and making decisions without them is not going to feel good. None of us feel like want to experience that loss of autonomy. And so as much as possible, and sometimes it takes some coaching from our clinical team or from our social worker, sort of coach and give guidance on how you bring in their perspective, how you do all of these things respectfully, but also understanding at the end of the day, you now have to make the decision.
Yeah. Well, we're certainly talking about a lot of challenges that caregivers face. And of course, being in the mental health field, this stress and strain of this, I imagine that there's a high rate of mental health challenges for caregivers. Can you talk about that? What are the rates of this and what kinds of mental health challenges do caregivers face?
So what we hear reported from caregivers, and we've measured this in our own studies, are high rates of anxiety, of depression. And those may have be pre-morbid. So those may be before they came into this caregiving role, that they were already sort of managing those. Oftentimes being someone's caregiver is not your only source of strain or stress, right? So people also have employment challenges that may happen, their financial stress, other family dynamics, and so forth. Unique to caregiving, though, we measure things like burden and strain. So that would be probably one of the more negative aspects. We also then measure and hope to improve with some of our programs the confidence that they can do this work, the confidence that they are doing it competently, that they are helping the person get through their day. It may not look like the ideal scenario they had in mind, but they're doing a great job. And to start to build that for those family caregivers.
Yeah, that's really interesting. I hadn't thought about this either. You're not getting any thanks from the person that you're caring for, which would be nice. But I
do have a few patients in mind I could think of, even very advanced stages of their disease. And they would still really, when I ask them, joke, right? Like, oh, how's she doing? She's taking good care of you. And they'll well up truly with gratitude in the moment. And so that day to day, it's unlikely you're getting much thanks. And I know a lot of people, it's really hard when you're not hearing that affirmation from your person or from anybody really around you. But it's still certainly in some families and some dynamics that may remain.
Yeah. I have heard statistics that as high as 50% of caregivers have depression at some point. And that does not necessarily shock me, especially hearing all the things you're talking about. So I think that, obviously the caregiver taking care of themselves is it something I'm sure you have to teach because you're so focused on this other individual, it can be consuming. But if you don't take care of yourself, you're not going to be as effective, right?
Absolutely. I mean, I think we've reused the quotes from the air safety training when you get on a plane, right? That you need to apply oxygen to yourself before putting it on someone else.
Okay, I like it.
So that comes in handy sometimes. I mean, I think there are also some interesting sort of cultural dynamics depending on your family's culture where there's some expectations and maybe you don't necessarily want to put all of this weight on yourself, but your other family, extended family may expect it and may also add other challenges when you do take that time away for respite. Respite, though, is so critically important as this disease progresses. The other thing I do try to remind my caregivers, though, is, no, I don't need it. I'm fine. The reality is you're a better caregiver when you take time away and come back. So it actually ups your game. And also, if you are my treatment, so, we were talking earlier about the treatments that we have for Alzheimer's disease and other dementias. The most powerful treatment I have right now is an educated and informed family caregiver. That's the best treatment. So I need you to take care of my treatment.
That is fascinating. I had not thought of it like that, but that makes perfect sense. Family, what kinds of signs or symptoms should caregivers look for in a loved one that might indicate problems? I mean, certainly we talked about personality change and maybe behavioral change. What kinds of things should a caregiver look for?
So I think we are honestly, as a society, way too focused on the memory changes, although I'm going to add that to the list. Certainly people notice like some repetition or some lapses.
Yes.
Frankly, and that really is specific to Alzheimer's disease. It does not address the other dementias that do not begin with memory loss and really may not have significant memory loss for some time. It's really more likely, though, even in Alzheimer's disease, before there are memory lapses, there are judgment lapses. So that abstract thought and reasoning can get us in trouble. The reason I think about that is that's when people are ripe for scam and financial exploitation. And in reality, most of your dementia care will be paid out of pocket. And so if we have now depleted the nest egg because of being a victim to a scam or entering into like major financial contracts that really weren't appropriate or well thought out because they just didn't have those skills. So, having some eye or someone who's sort of transparent and open about what's happening with finances so that at least someone can have an eye on the accounts is really helpful. So that's one of the earliest pieces. Of course, I mentioned memory lapses in our Lewy body friends, right? So for someone who has Lewy body disease, those really active nightmares, those vivid nightmares or vivid dreams, acting out dreams, those are my folks who are most likely to have a visual hallucination early. So if you're 70 plus years old and you're having a visual hallucination, this is not late onset schizophrenia. Lewy body disease until you show me otherwise, right? So some of those sorts of changes where those things often get missed. And then personality change and then or potentially a decrease in vocabulary. So for someone who maybe like me is very verbose, who does a lot of speaking, and I start to say less and my vocabulary seems to sort of shrink or I'm having trouble like finding the right word for what I'm saying, then we might think about changes in our frontal lobe and frontotemporal dementia. So especially at younger ages. And that disinhibition is the other piece in terms of that personality change. So, for our frontotemporal friends, maybe these are folks who are having changings and it can be as early as in your 50s, right? At work, difficulty performing at work, managing the checkbook, or difficulty in our relationships. So I think, we love our psychiatry colleagues across the hall. Many times, though, it's our frontotemporal dementia patients who get sent to psychiatry first before we realize this is a neurodegenerative process. So, it's really that change from baseline, right? Change from something that has been a part of this person's being, their mind, as you mentioned, for a long time, and we're seeing significant changes. We should probably be looking into some neurological changes, as well as psychiatric, right? It certainly could be either or, and they're not mutually exclusive.
Right. So all of these cognitive changes in personality, behavior, including wandering, we haven't talked about. It seems to me that gets wandering and agitation really get people into a lot of trouble and may lead to institutionalization, of course.
Absolutely. So, we like to keep an eye out for someone who is at risk for wandering. And that does tend to be somebody who is more amnestic. So, memory loss is more at the forefront.
Oh, okay.
And they're mobile, right?
Yes,
so, you have to have both available. And so we, it's just talk about sort of companionship, constant, not necessarily, we might use the word supervision, but someone needs to be around, right? We can't really do a lot of alone time. I do encourage people to register with the special medical alert program for people with dementia called Safe Return. In some areas, there may be scholarships through local advocacy organizations, but I think a reasonable amount to pay for that monthly subscription. I have one patient, I've had in our practice, we have a few sort of famous patients. We're like, this happened in the last year. This young lady has been very anxious to drive the car, and her husband has been absolutely vigilant about keeping that access to the car at bay, but just happened to, in a moment of lapse, set the keys down on the counter. She saw them. Off she went. She was gone about 6 hours and trying to work with law enforcement across multiple counties. She drove herself to a very fine restaurant, as it turned out. A nice part of Atlanta. I don't know quite how she made it there. We're all sort of scratching our heads, but the staff sort of realized something was a little bit off. For one thing, she had one shoe and one slipper on. So that was okay. But she had that Safe Return bracelet. And so they were able to find her that evening, and they called the family, and there she was, safe and sound, which was, the happiest ending. You can, many times it doesn't turn out quite that positively. But wandering while driving is also a component there. So that's really where people can cover a lot of distance more so than when they're walking. But, when people are walking, we worry a lot about wooded areas, and it really can have some tragic consequences. So encouraging people to just have a person around, right? I know early in the disease, they may not need somebody to help bathe, toilet, dress. They just need someone present. And so we really get away from a lot of alone time pretty early in the disease if we're coaching families.
Yeah, safety is obviously another issue we didn't talk about, paying attention to safety. And, it's interesting. I've had texts on my phone not that long ago, describing a person, an older person who is missing. And that's kind of what you're talking about, right?
Yes.
It also occurred to me, you're talking about the different types of dementias, and I realize we're realizing more and more that there's a lot of the patients have mixed dementias, for instance, Alzheimer's and vascular at the same time when you do scans. So it's not always that straightforward and simple, is it?
It is absolutely not. I think that's really where, for so many reasons, you want to have a dementia specialist involved in your care. And so certainly for somebody who's got some frontotemporal, but maybe on biomarkers also has the proteins for Alzheimer's disease. So now you're really customizing and creating a precision approach for this person based on their symptom expression and what is most prominent and most sort of concerning or high risk at the moment. So vascular risk factors, vascular disease in all of our dementias is, I think, maybe even more so than the growth in the aging population. It's people aging with vascular disease, truly. Yeah. That is creating not just dementia itself, but we're probably seeing dementia symptoms earlier in people who may have died from another cause. And we may never have seen their dementia symptoms other than they had these vascular risk factors. So longstanding high blood pressure, diabetes, vascular disease doesn't just affect your heart. Right. If you've got heart disease or peripheral vascular disease, you can expect you probably got some changes in the brain.
Yeah. And of course, our population, we have an epidemic of obesity and diabetes in particular. So yeah, that's a really interesting point. Let's shift gears a little bit if I could now. What is comprehensive dementia care and how does it improve quality of life for both the patient with dementia and their caregivers?
Comprehensive dementia care is a phrase or a term we coined among 6 models, actually, that are recognized as providing this comprehensive care. We all do it a little differently. So I represent and founded Integrated Memory Care. It does full-scale primary care and dementia specialty care. That's unique to us. Others have different approaches, but we agree on common elements that we all provide. So, for example, that there is clear assessment and staging. So maybe people who are coming to these practice models have a dementia diagnosis, but let's make sure we're clear. What is the underlying cause? What is the stage that we're at today? And let's make sure we're asking the questions to assess those neuropsychiatric symptoms, because if you didn't assess them, well, they're surely not going to get treated. So that's one component of it. Another component is that the caregivers are an engaged member of the team. That's how we would say it at IMC. But that might look in different ways. And there's some very simple things practices can do to engage caregivers. For example, if you have a check-in desk at your clinic or your health system, is there one chair or two? Like, is there a seat literally for the caregiver in the space? Is there a seat for the caregiver in the room, in the exam room during a visit? And so I call that sort of making space in the conversation. And then in a comprehensive model, you're also offering services specifically for the caregiver. So maybe that's a class or support group, or you're connecting with them with those services in the area. Right. Another component is that you're coordinating that care. So you're coordinating or helping them to navigate through, let's say, a support group at a church and maybe a day program for respite. And maybe you're coordinating with other specialists who might be involved in this person's care. And so this is sort of care that provides both the focus on the dementia symptoms for the person as well as the caregiver, and then navigating and coordinating the care across different sites.
I see. How common are these models? How common are they? How commonly available are they, I should say?
They are more available than they used to be, and I think all of us are working to make them more available. So these 6 models that are comprehensive dementia care, most of them have more than one site. They've been working to replicate their model across different health systems, so health systems can adopt it. The 6 of us also are participating in a collaborative now, in which we have support from the John A. Hartford Foundation so that we can make our models even easier and available to replicate in other systems. So for us, for example, we are putting together, so we have our manual, we have tools that other sites can use. We can provide coaching to their clinicians as they stand this up, both on how to deliver the care and how to document it, how to get paid for it, which matters as well. So probably the most replicated out of the 6 of us is probably the UCLA Dementia Care Program, or the DCARE program. They've been funded to replicate across multiple health systems. The same is true from Care Ecosystem, which was founded at the University of California, San Francisco, so up the coast from the high school. Yeah. So Care Ecosystem has also been replicated. I think that one of the challenges for us, and the way we found one another, was part of a report called Scaling Comprehensive Dementia Care Models. Why are they not more scaled up? Why are they not more commonly available? Part of that is the way that we're paid to do healthcare and what's paid and what's not paid. And that doesn't necessarily align with what's really needed for these families facing dementia. So that's sort of how we got together and then started talking about how we could scale up. And that one of those barriers was making it more replicable and then making sure people can get paid.
Well, you just made me think. I can imagine a huge health cost offset here because you're probably decreasing institutionalization, trips to the ER, and so on. I can imagine this is a much more efficient model.
It absolutely is. I mean, it's one of those nice times when better care aligns with lower cost care. And so, right? So how nice for us. I think one of the challenges in dementia care is that we don't have great alignment between who pays up front and who saves on the back end.
Right.
So, and there's also the realization that so much of the care, again, is out of pocket. That means it falls to patients and their families to pay those costs at then their own detriment sometimes. So imagine you are in your 50s, should be in your highest earning decade of your career. You have children who are in college or headed to college, and you have a parent for whom you're paying $10,000 a month for assisted living.
Oh boy.
So if you are now depleting your retirement fund, then you now will retire in poverty. If you are depleting your children's college funds, now they have student loans, and we know the student loan crisis is. So the thing about dementia care, I think we all in our minds think, well, this is an aging problem. This is a problem of the aging population. It is a family problem. It affects multiple generations.
Right. Wow. That's very interesting. Is there a resource or a website someone could go to see if there's one of these places that's near them?
There is not one. This is actually a side project I've been thinking about for a while.
Okay.
I will say the Alzheimer's Association has an older site called Community Resource Finder.
Okay.
That was created, I believe, so that people could find a diagnostic center.
Okay.
And so, but I know that not all of that information is up to date. I think it's just not something that they've been able to keep up with. And so that's the only one I know of that exists, though. But I'm telling you, I will expect really within the next few years, you will see a centralized site for memory clinics. There are state level networks in multiple states. And then there's our comprehensive models. And then there are a number of startup innovators who are outside of the academic world who are really trying to innovate and be creative in ways to reach more of this population.
Well, that's terrific. It would be really wonderful for people to be able to find, of course, caregivers, patients, but also clinicians to find places like this. All right. Let's focus in specifically on the integrated memory care clinic that you co-created. And you already mentioned one thing that makes it unique, but tell us more about it.
So integrated memory care was a practice that we opened in 2015. It's part of the Emory healthcare system here in Atlanta. And it is at its core doing full scope primary care by geriatric specialists, doing full scope dementia specialty care as well. And then also offering services for caregivers all under one roof or under one practice. We have a clinic, so it's an outpatient clinic, just like any of us would have in our primary care setting, except there are, small, subtle differences that make a difference if you know what to look for, right? So, we make space, obviously, for that family caregiver to be part of the practice as much as for the patient. That means we do individual visits with the caregiver about their person, both by the nurse practitioner as well as psychotherapy appointments for that caregiver or the family. The team is fairly robust. We are a nurse-led and physician-supported model of care. So your visits or your primary care will be with a geriatric nurse practitioner like myself or some of our others. We also have geriatric psychiatry nurse practitioners in-house as well.
Right.
A social worker who can help do some of that psychotherapy, teaches classes, and also connects people with those community services, registered nurses. And then when you're part of a large system, this really is very distinct and different. I know it may not be the case in smaller practices, but if you want to make an appointment with us, you call us directly. If you want to get a call into the nurses, you call us directly. So we are very accessible to our patients and families, certainly during normal business hours. And then from the beginning, we've always had a direct line for family caregivers who are having an urgent or an emergency situation after hours, holidays, weekends.
Yes.
So they get right to one of our providers, which I will tell you, I think about 80% of our calls that we take after hours tend to be caregiver support. But certainly this is the way that we have avoided emergency department use, avoided hospitalizations that were unnecessary. We are really quite good at that. Our other outcomes we're about to publish are our improvement in deprescribing of high-risk drugs and then avoiding inappropriate tests. Yeah, it's huge, of course.
Those are both huge. I'm on a personal mission to deprescribe anticholinergic medications for a variety of reasons, and this is certainly one of them. That's great.
Good for you.
Yes. All right. Well, this sounds really terrific, and hopefully it will be replicated and become more widely available. Let's talk about something else here. Last year, the Centers for Medicare and Medicaid Services announced this new voluntary nationwide model called the GUIDE model, which stands for Guiding an Improved Dementia Experience Model. And apparently it's going to launch this summer. Can you tell us about this and what it entails?
I would love to. I think so much of the work that we were able to document from the comprehensive models that exist, we all have positive outcomes. We all have demonstrated cost savings to Medicare. And so really excited that they certainly were paying attention and that they've now opened this up more broadly. So GUIDE will enroll practices on a voluntary basis. You can apply. You did apply. That due date was this past January. To either be an established model like ours at Integrated Memory Care, or you can be a developing model. If you're a developing model, you have until July 1 of 2025 to organize how you'll be meeting these required elements to deliver the care that's included. So it is specifically for the dementia care services, which includes caregiver services inherently. So that's dementia specialty and caregiver services. And rather than this will actually let practices, if they're providing the care that's required, it will let them deliver, for example, caregiver services, which were not covered at all by Medicare or maybe there's some newer codes coming out. It lets them get paid for that care that happens in a per member per month basis rather than our usual fee for service.
Right.
And of course, it wouldn't be, Medicare, the new version of Medicare, which is much more interested in value and outcomes of care as opposed to services delivered. If it didn't include a value-based care component, which is that you will be reporting and held to outcomes, both for the quality of life for the person with dementia, the burden experienced by their family caregivers, the medications that you're prescribing or deprescribing, and then their use of acute care utilization and long-term care placement. So nursing home or institutional placement. So you'll be reporting on those, and then your per member per month payment will be adjusted based on how well you are performing in comparison to your other practices who are also participating in the GUIDE program.
Oh my goodness.
Once
competitive.
you open up a GUIDE practice, now, so this is for traditional Medicare beneficiaries, right? Because it's paid for by CMS. So only traditional Medicare beneficiaries are eligible with a dementia diagnosis. You as a practice will enroll them. And then when you enroll them, you are certifying not only that they have a dementia, but what stage, whether there's a caregiver present, and at what degree of burden or strain the caregiver is experiencing.
Okay.
And then these patients or beneficiaries are placed into 5 tiers for risk stratification, and payment is commensurate with higher risk. So then you are being paid more because we understand someone who, for example, has no family caregiver and has a moderate or late stage disease is probably more complex and requires more of your staff's time to support them than someone who is maybe early stage disease, has a caregiver, and the caregiver is doing really well at the moment. So you'll continue to reassess that, but that is how the payment structure works.
Boy, that certainly makes sense. Now, I've reviewed this model, and it seems that two things stood out to me. This is two elements of this. The first was care coordination and caregiver services, which you mentioned, and then having an interdisciplinary team, including a care navigator, which I found to be an interesting concept, and then obviously clinicians with dementia proficiency would be ideal. So it seems like a very interesting way of organizing this.
Exactly. I really love the emphasis on an interprofessional team. It's been honestly the secret of our success at IMC all of this time. A high functioning interprofessional team is like the magic, right? But we don't reward it when you pay the one provider, the billing provider, right?
That's a good point. Right.
So in this way, you're paid for a monthly amount. You are required to have two staff members who you mentioned. So you have a dementia specialist, that is a nurse practitioner or physician assistant who has experience and should be board certified in an area related. So in our practice, we have a number of gerontology nurse practitioners or adult gerontology nurse practitioners, right? With a lot of experience in dementia care because it's all we see.
Sure.
The second person on your team is a dementia care navigator. It is less well defined. It's honestly a newer and emerging role. There is, I think, just one publication so far on the dementia care navigator. For us, our team honestly shares the responsibilities of a care navigator between the RN and the social workers. So, but, we designated one person who will be our dementia care navigator. And then beyond that, staff the team how you need to staff the team in order to provide these services that you're required to provide, all to get better outcomes, a better quality of life for this person and their caregiver, and to have most appropriate care. So I think you have a lot more freedom to sort of staff and to design care delivery models in the way that it makes the most sense for your population, maybe for your health system or your local culture.
Yeah, that is fascinating. Again, hadn't really heard about or considered this level of comprehensiveness and wraparound, if you will, and obviously coordination and communication. It is frustrating to practice in this fragmented system that, as you said, that we call a healthcare system, but that's probably a little optimistic. And I'm thinking about folks listening, clinicians who are listening to us now, many of whom may not be fortunate enough to be near an academic center or another place that has one of these comprehensive models. So what kinds of advice would you have for a provider who is trying to not only take care of the dementia patient, but to support the caregiver? What kinds of things could they be doing to help with that?
I think there are a couple of big issues right now in dementia care, and I'll just say in primary care, which is, really where we found our sweet spot. And there's some low-hanging fruit, which is, I think, good news. It doesn't get, to like perfect scenario, but it goes a long way. First of all, we have a challenge in this country when someone with subjective cognitive decline, so they're personally observing changes in themselves, cognitive, behavioral, or functional symptoms, those are changing, and they bring that to primary care, that there should be a further evaluation. It's perfectly within the scope, by the way, of primary care to make that diagnosis. Okay. So, getting that good history. If you need to do a referral to neuropsych for testing, those are more widely available than most people realize. That might be a helpful component to your diagnostic process. But most people coming in for that diagnosis are moderate stage. So, again, that's a pretty sort of standard guidelines for working that up. Really just understanding what's going on, doing some basic blood work. You might do structural imaging. Paying attention to which symptoms presented first and are most prominent, and neuropsych can be your friend and kind of helping tease some of that out. So that's one thing. The second thing is then making space for the caregiver, right? You can do visits only with a caregiver without the patient present. That's paid for today. And people are gobsmacked in my practice. When they come in as a new patient, the first visit is with the caregiver alone, with the nurse practitioner. I want to hear all the symptoms. I want to hear the course of disease. I want to hear, especially about the psychiatric symptoms you may not feel comfortable with. I want to hear the diagnostic. I want to hear the language we use. You are my best source of data because you observe this person every day. So giving them that space will make your cognitive assessment visit, which is another CPT code Medicare pays for, cognitive assessment and care planning, gives you, they expect 50 minutes to do all of this work. So I know sometimes in busy practices, we're like, when would I do it? Do a cognitive assessment and care planning visit so that, have the time to be devoted on that. And then having that caregiver present for that visit will make the whole experience, I think, much more helpful to you. But so those are some really basic things. And then your area agency on aging, which covers every zip code in this country, has a hotline for dementia services. Everything from home care agencies, adult day programs. You're looking for respite probably at that level, residential care, guidance on how to find, an assisted living or a senior living community that's going to be a fit for your family. So some of those basic community referrals are helpful. And then don't forget your local chapter of the Alzheimer's Association, which does serve more than people with only Alzheimer's disease. So they're also a terrific resource. They have a 24/7 hotline as well for caregiver support. So they might not be able to answer I've got a rash, or I think there's like a, is this an emergency department visit? But for caregiver support calls, which are a lot of them, your Alzheimer's Association chapter can field that. People just have no idea that it's available to them. So recognizing the dementia, making space for the caregiver to be present, and then just your area agency on aging and your Alzheimer's Association chapter for referrals will go a long way. I'll give you 2 really excellent resources available to people in practice as well. So one is called the CARE Toolkit. It's KAER. That's put out by the Gerontological Society. It's free. It's guidance for you to kickstart the conversation, assess, evaluate, and refer. And then the second is a web platform or an app called RON, RON, which is a free app for families. It answers all the questions they have about dementia that you don't have time to answer. They're answered by clinical experts. They cover all the dementia types, and they have clinicians, caregivers, people living with disease, attorneys. I mean, everyone who sort of surrounds this world with a very large question bank, and all the answers are 3 minutes or less.
Well, those are terrific resources. Thank you so much. I think that provides providers with resources and ideas here, and maybe help people connect. Near us in our neighborhood, there is a geriatric day treatment program, a day treatment center. That is a terrific, we talked about respite, maybe a terrific place where someone can go, and people may not even be aware such things exist. So I think this is extremely helpful. And then, of course, maybe doing some basic assessment of the caregiver for their mental health and connecting them with counseling or mental health resources. Would that be appropriate?
Absolutely. You may also find outside of this patient who has a caregiver with them, many of your patients are caregivers themselves. And so and I would include that if you're doing an assessment of social determinants of health, caregiving is also very similar in that way that it has so many other implications. And so I think paying attention to caregiving as a role, whether this is the patient in front of you who is serving as a caregiver that may be invisible to you, or this is a caregiver who's coming with your patient, but certainly doing some basic assessments of their strain and their burden related to that role is be very meaningful, and to get them to helpful resources can make a difference for them and the person they're supporting.
Yeah. Now, you've mentioned strain and burden a couple of times, and I don't want to assume I know what you mean. Could you just define those terms a little bit for us and how to assess them?
So caregiver strain and caregiver burden are 2 terms I think we use a lot because they are the title of the assessment tool that we use. So we have a nice, reliable, and valid tool. Strain may be more about, I'm going to have a hard time putting this into words as a definition, but some of the questions, for example, are things like just feeling like pulled in multiple directions. Like I'm concerned for this. I've got these other things kind of weighing on me. And so maybe it's employment or family or finances, right? And burden may be more about, it tends to be a little bit more about their direct caregiving role. And so how much like sort of weight they're feeling related to the actual caregiving that they're doing for their person. If that sort of helps to separate the 2 a bit.
Yeah, so strain sounds like stress, a proxy for stress, if you will, the stressors and the level of stress. And then burden may include how much of this falls to you alone, let's say. Are you getting any help yourself, or how much care does this patient require at this point, for instance? Because that's obviously going to change and evolve.
Right.
So those are helpful terms. Thank you. I'm thinking also about, we mentioned earlier that we don't really have terrific treatments for the Alzheimer's or for dementias themselves as far as disease-modifying agents. I know we all put a lot of hope in the amyloid hypothesis, and we have these now, a few amyloid drugs that lower amyloid, but they don't seem to make the kind of impact that we had hoped for, obviously. And of course, they're controversial because of cost and what's the potential benefit relative to the cost. But I think it's an area of very active research. It's very exciting. There are some very interesting novel mechanisms and new drugs being looked at. So, of course, I'm sure we all hope for that. But in the meantime, an area that's getting a lot of research and that we've started to have some drugs getting very close to the market with one recent approval are drugs that treat the neurobehavioral consequences. We mentioned earlier agitation. There's a drug that was just recently approved, brexpiprazole, an atypical antipsychotic, was approved for agitation associated with Alzheimer's disease. And there are several others non-antipsychotic drugs in development. Obviously, we have medicines for depression, we have medicines for anxiety, we have medicines for the psychotic symptoms. So I think that deploying those resources intelligently is also going to be critical here and would help with caregiver strain and burden. Is that true?
Yes, absolutely. I mean, and that is, I think, has been part of the total picture for some time. I was doing a talk on some of the new drugs, and I went back to memantine and when it was approved and indicated for vascular dementia. And, it really wasn't the disease modification or the symptom improvement for memantine. It was their ability to do ADLs for longer and delay residential placement, which also was reducing caregiver burden. So there was less physical support needed for those patients who were on drug versus placebo. So absolutely, I think the better treatment for dementias and the different symptoms related to dementia are certainly better for the person experiencing those symptoms, but for the person who's needing less support or needing maybe a different kind of support that's not quite so challenging to provide. Absolutely. I mean, some of the challenges in like disease modification are a couple. One, dementia due to Alzheimer's disease is more complex than one thing, right? So, there's so many other factors that are likely going into the manifestation of those symptoms and the brain changes that we're seeing. And then the other is some of these drugs are, for example, really good for Alzheimer's disease, but not appropriate for dementia. Starting to separate those two, it's probably good for all of us as clinicians. The problem is people with dementia are the people who are coming to us for evaluation and for services, right? They're presenting because they have symptoms. But when they have symptoms, that means they've had disease for, looks like on average, 18 years. And they were asymptomatic living with Alzheimer's disease, and we did not know it. So finding those people who have Alzheimer's disease and no symptoms is really the trick now. And then, yes, at ongoing, there are different mechanisms, certainly, that I think have been really interesting. Measures of, protein burden, for example, tau versus amyloid. Tau correlates much more closely to symptoms. So then when you start to improve or reduce the tau burden, you actually can see some symptom improvement. All of this, I think, is just about, there's nothing that we found that's going to change that symptom expression to end of life is about 10 years. Like that, we've not changed the lifespan of people living with disease, but we are trying to change the quality of lifespan, right? So maybe more years spent in early stage, even if you have a faster decline later, or more years spent in stages where you don't have some of these more distressing psychiatric symptoms.
Yeah. And of course, delaying placement and institutionalization would be nice as well. Well, this is interesting. As someone who's done a lot of clinical trials, I find the outcomes you're mentioning and measuring to be really fascinating. And maybe perhaps even the FDA will use those, not just symptom, but, these other quality of life type measures. That would be nice. Well, back to the guide model, this obviously has a lot of promise and really sounds very interesting. It's not just a way of thinking about the services and the care, but also financing the services. Sounds very novel. Are there any other unmet needs that still need to be addressed that you could help our audience with?
Well, so I'm always going to say, I think the guide model is really powerful. People hopefully will get many more people, hopefully, will get dementia specialty services, right? But I am always going to be biased toward offering those under one roof. Because, even if you have an amazing dementia specialty clinic where they offer caregiver services and you have separate primary care, you still have a fragmentation, right? So, let's think about the classic urinary tract infection, right? So we know UTI and someone with dementia is going to cause delirium. So maybe they don't present with the pyuria and the fever, but they certainly are having a lot of confusion, a lot of behavioral symptoms, right? So, who manages that, right? So the symptoms are dementia symptoms, or they're going to appear like dementia symptoms. The management of a UTI is a primary care space. So the fact that, the brain is connected to the rest of your body really begs the case for having all this care under one umbrella. So we don't have anything that's encouraging that, I think, but I get it. We have to begin with, let's just get people a timely and accurate diagnosis, which is a whole separate field of work. And then after that diagnosis, let's get them an excellent comprehensive care delivery model. That would be really powerful. Now, you may see in GUIDE, if you look at it, there's also a respite benefit for those beneficiaries. It's a max of $2,500 per year. There are some challenges in implementing this. There's some big challenges implementing this. Medicare is not paid for respite before. They've set some rates for day programs and for in-home care and for overnight stay that seem pretty out of alignment with the industry charge. So what they're willing to pay is not what the industry charges. And so that's a real challenge to figure out how to make those two match up. My sense is, we're rolling this out. It's an 8-year demonstration project, but it's a demonstration project. And so maybe we'll get some closer alignment there, but respite is going to continue to be a challenge. And then remember, in my population, about 45% of my patients are traditional Medicare beneficiaries. That means 55% are not. And so if they're in private insurance, Medicare Advantage plans, they're not going to have access to the GUIDE program. And so we have a whole world of folks who will not necessarily get these services, at least have them readily available because they're paid differently.
Well, thank you so much. Those are excellent observations and thoughts. And I hope that our audience has found this to be as interesting and helpful as I have. Carolyn, I really want to thank you for your time, and I really want to compliment you on the work that you're doing. And I certainly hope that others are able to implement what you're doing and that we get more of these kinds of integrated clinics rolled out. So thank you.
Thank you so much for having me. I love talking about this.
Yes. Any final words?
No, I think, yes, of course. So final words might be, I think just paying close attention to people living with dementia. It's not just your usual chronic condition. They're not going to be able to self-manage. And so recognizing it when it's present and then putting supports around people is absolutely worth the time invested. You will absolutely make a change in someone's quality of life, in their ability to stay well for as long as possible. And so regardless of what happens with the cure or with treatments, know that you as a clinician can play a really meaningful role in supporting someone just by assessing symptoms and doing your best to manage.
Great. Well, thank you so much once again. And I want to thank you, the audience, for listening. For more podcasts, you can always find us wherever you find podcasts. And for our podcasts and other educational resources, you can go to our website, which is neiglobal.com. Thank you for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.
A rate cutoff for the 2024 NEI Synapse is fast approaching. If you have yet to complete your registration for the conference known as the Nerve Center for Optimizing Patient Care, do so today before rates increase. The 2024 event is being held April 19th through the 21st in person at the Red Rock Casino Resort and Spa in Las Vegas and via simulcast online. Secure your spot today at nei.global/synapse.